Welcome, everyone. It's so good to see you here today. So I'm with great joy, I get to present Rachel Colston, who's our presenter today. She's a mental health therapist working in the state of Washington on the occupied land of the Coast Salish tribes. In Rachel's clinical work, they orient themselves towards liberation psychology, which entails collectivism, abolition, decolonization practices, affirming diverse identities, and understanding interlocking systems of oppression with a trauma-informed person-centered focus. On their days off, Rachel enjoys playing video games, drawing, painting, knitting, and spending quality time with their family and friends. Without further ado, I give you Rachel. And also just a gentle reminder that I'm going to be pasting the CEU link in case you want it. And my daughter Melina says hello.
Thank you, Salome. I'm going to go ahead and share my screen to get us started. I want to thank everyone for joining us today. I'm so glad to be with you. So to start, we're going to be talking about today becoming an anti-racist healthcare practitioner, a clinical praxis. A little play on words, but also intentional in that it is an active and engaged practice to be an anti-racist healthcare practitioner. It not only encompasses your personal, but also your clinical work. Moving on. So today, I invite you to not only check in with yourself throughout the presentation, but I also just thought for a second here, let me make sure that, can I get a thumbs up if everyone can hear me? I just thought about that. Okay, great. So for today, I invite you to, really check in with yourself throughout the presentation, check in with your body. I invite you to take a breath whenever you're noticing any tension throughout your body as you follow me through this dialogue. So we're going to be learning and obtaining an understanding of racism in the history of healthcare in the context of the United States. I'm going to invite you to reflect on the ways that we bring prejudice, racism, and harm into healthcare. And I'm going to invite you to explore and be curious about a new framework for integrating anti-racism into healthcare provision inside and outside the clinic. So briefly, I'm not going to read this entire thing, but just briefly, a few definitions. First off is capitalism. It's an economic system based on the private ownership of the means of production and their operation for profit. So currently, we reside under a global apparatus of capitalism, and thereby not only our countries are impacted by the effects of capitalism, but also our states, our communities, and then down to our bodies and minds. Next, I am going to define socialism. It's a political, social, and economic philosophy encompassing a range of economic and social systems characterized by social ownership of the means of production as opposed to private ownership. There's not one definition of what socialism is, but just naming that liberation psychology and this orientation that I tend to adhere to utilizes this idea of collective need, of the public, the collective cooperation, but it also encapsulates multiple types of socialism, and there's not one one clear definition. And so many socialists disagree on whether government, particularly existing government, is the proper form for social change. And then we come to colonialism. It's a practice or a policy of control by one people over other people of areas or areas, often by establishing colonies and generally with the aim of economic dominance. So just think about and check in with your bodies as you think about the idea of imposing a religion, a language, an economic system, culture practices onto another group of people, another community. Um, it's colonialism is associated with, but is distinct from imperialism. Imperialism is a policy or ideology of extending rule over people and other countries for extending political and economic access, power, and control, often through employing hard power, especially military force, but also soft power, as I referred to earlier. It's, offloading an economic system onto another people. And then we have decommodification. It is the strength of social entitlements and citizens' degree of immunization from market dependency. So this can look like taking, for example, housing off of the for-profit market. It can mean like subsidizing housing industry to make it more equitable and make it more accessible to everyone, and not have it tied to profit or businesses. And this can extend down to healthcare and mental health care. Um, is our current mental health care and healthcare system decommodified? Just something to think about. And then a quote from Paul E. Farmer, structural violence in global health is one way of describing social arrangements that put individuals and populations in harm's way. The arrangements are structural because they're embedded in the political and economic organization of our social world. And they're violent because they cause injury to people, typically not those responsible for perpetuating such inequalities. So asking yourself, how is it that, for example, legislators have access to healthcare, publicly funded healthcare, meanwhile legislating to keep healthcare privatized. Just invite some curiosity around that. And then we have neoliberalism. It's a term to describe the 20th century resurgence of 19th century ideas associated with free market capitalism. It's marked by privatization, deregulation, globalization, free trade, austerity, and reductions in government spending in order to increase the role of the private sector in the economy and society. For example, keeping healthcare largely privatized, keeping education largely privatized, or, run by the nonprofit industry, for example. And so we're going to take a visit with the extensive history of racism in healthcare in the United States. I'm not going to explicitly highlight anything inherently, physically violent or really graphic, just because I feel like that's more along the lines of voyeurism. Instead, I'm going to highlight a more system-centered way in which structural violence and racism has taken hold from the United States' founding. So a quote from Paula Freire here. Looking at the past must only be a means of understanding more clearly what and who they are so that they can more wisely build the future. So we're looking at this from a hopeful lens. And so we see this starting with the colonization of the Americas, or for those who observe the Turtle Islands tribes. And we see that there's a use of medical knowledge through colonial medicine and diets, for example, imposed onto indigenous tribes. We see in the 1980s, for example, there was European medicine, United States medicine imposed on tribes surrounding military posts who were then actively colonizing regions. Or, in the we see in 1832 an act passed that allowed tribes access to smallpox vaccinations, but these were distributed by liberal or nonprofit and religious institutions rather than um, allowing for tribes to have sovereignty over their own healthcare. We see things like churches and residency schools imparting this westernized European medicine. And in a lot of places, arguably all, criminalizing healthcare and health and wellness indigenous practices. So we see lower life expectancy and the disproportionate disease burden exists, perhaps because of inadequate education, disproportionate poverty, discrimination in the delivery of healthcare services in indigenous peoples. And not only that, we see in 2018 a report showing that the United States government has not adequately funded Indigenous American health programs, including mental health, um, leaving many um, Indigenous communities without the ability to provide quality health care. So thereby enacting structural violence again, right? Not only imposing the act of colonization onto Indigenous peoples, but then again, reifying and not treating this historical generational trauma by not funding, health care programs to address this. So with Eastern Americans, for example, Eastern Asian Americans, for example, Eastern Asia, a phrase that is in part a result of colonization in Asia. We see that this model of colonization has followed, you know, Eastern American immigrants and their descendants into the United States. Um, so these same barriers that existed not only in Eastern and Southeastern Asia and Oceania, but then now also due to colonization, um, following it into the United States. And not only that, exporting it out of the United States onto other people. So we see the harmful model minority narrative, for example, which is rooted in colonialism, this belief that Asian Americans are inherently more healthy, are inherently more hardworking, inherently are more in control of their own healthcare needs. Whereas in reality, the US has created high rates of uninsured and lack of access to healthcare. The US doesn't necessarily make sure there's access to translators, for example. It's systemically impoverished large groups of Eastern and Southeastern American peoples. Having infrastructural issues like scarce transit and expensive childcare, limiting access to diverse clinicians because of, for example, legislation creating expensive healthcare education. And then we see a minimized these minimized side effects of European-based medicines and lack of education about side effects and impacts of utilizing European-based medicines. And this is all resulting from a neoliberal economic system. And then we see things like the inability to schedule takeoff work or, having difficulty understanding symptoms without use of medical jargon. And all of this is not acknowledging the need for cultural cultural needs to be met in the healthcare space. And then we have with the Latina and Latinx community in the United States, historical healthcare discrimination. Um, the system has made preventative care and health care education largely inaccessible. Um, Often low levels of education and income create low access to health insurance. And then we have the high costs of medication. We have um, the limited education on the parts of clinicians on culture markers of Latino, Latina, and Latinx cultures. Um, so we have clinicians ignorant of folk healing or religion and its importance in healthcare, or language around individualism and individualization of the body rather than the collective body. Or we have lack of knowledge of altruism. And as you could see, largely economic status is the issue here. Access to private insurance drastically declines healthcare quality. Um, and so historically, we do see activism, we do see collective action to address this on the hands of United Farm Workers, agricultural workers, um, and we see here on the upper left hand corner, um, a group of activists trying to work to create a medical insurance program for members. And so as you can see, these things are systemic racism and structural violence because they are structures in place that are embedded that overwhelmingly create and reify cyclically low income, unemployed, and BIPOC communities and create vulnerability to harm for these communities. And largely on the part of what happens in legislation and what happens on the structural level. Race in the modern world has been inextricably linked with class, and putting BIPOC communities in the center is what is needed. And so, how do we enact an anti-racism in the clinical scope? It's not something that is a treatment. It's not something that is a pill that can just be given. It's something that's embodied. As I like to say that this is a full contact sport. It's going to be uncomfortable, but it is possible. It's possible, and it's possible together. I invite everyone to dig deep into your own history, your family, your upbringing, your historical trauma. I invite everyone to think about their identities, their privilege, and education. I invite everyone to create an inner and outer awareness that connects you with yourself and integrates you and your ancestry into the past of the world. Understanding this interrupts you from viewing yourself as separate from the world and what happens in it. As I said before, it's embodied, it's experiential, and it's an experimental practice. I invite everyone to understand their own implicit bias and explicit racism. The fact that we've learned things means that we can challenge our thoughts. Understanding that not that clinical research is not the rule. Ask yourself, is your perception of a given community always true? For example, the belief, how many of us have been told that Black people have high pain tolerance? And when in fact, this idea is rooted in slavery and colonization. Or how many, as I said before, people have been told that Asian folks are model minorities, that they inherently perform well in everything, that they're hardworking and are typically very healthy. And also, how many of us have what can you see in your life that has reinforced this idea? What systemically have you seen that has supported you in believing that this is the rule? And then I invite everyone to let go of the idea that you must be the martyr in the healthcare field. Um, this is deep rooted in European colonization and white saviorism. Um, Violating your own work boundaries will burn you out and leave you an ineffective practitioner, specifically to BIPOC clients and patients. 1 in 5 healthcare workers left their work over these past 2.5 years, largely due to burnout, largely due to unmet needs in the workplace. And studies have shown that when clinicians do not meet their personal and emotional needs outside of their work, more ethical violations arise. You can see that clinicians sometimes start seeking inappropriate personal fulfillment in their work. And continuously ask yourself and interrogate and be curious about who is it serving to violate boundaries, neglect self and collective care, and overwork yourself. So in the clinic, I invite you all to take a look at, I'm not going to play it just to avoid any copyright issues, but Jules's comment at 1857 timestamp on Tracy McMillan's Cotton Thick. It's a book about an academic who in a lot of ways was able to escape a certain social class, but due to racism was unable to escape the impacts of racism. And it's just highlighting how for people specifically in the United States, people of color, um, race is inexplicably linked with our social economic status. So when a person of color states something about their body that they're experiencing, it's the this is the rule to listen and validate them, meet it with curiosity and non-judgment, and investigate further if possible. We know, for example, that Black Americans are 50% less likely to receive life-saving treatments. We also see that Taiwanese patients, for example, feel apathy from their doctors when they're diagnosing them. I invite all of us to become scientists in understanding and trying to learn about our bodies and mind. Don't assume we know what's going on. Become artists in our practices by helping our clients, by connecting them with full services for their bodies and their minds. This will help clients and patients learn to trust and reinforce themselves and reinforce trusting themselves and their mind and body awareness again. Something that through capitalism and racism has been gaslighted, has been traumatized, and has been evaporated. Be open to with your client or patient. Um, of making mistakes, it's going to happen. Repair the relationship with your client or patient. Ask questions about their personal experience without assuming. Everyone is different. Be mindful of how you react. Are these your emotions showing up, or is it theirs? Avoid, as Dr. Megan O'Reilly says, forcing them into a chalkboard moment, forcing them to teach you about their culture and their identity. Direct them back into what their identity and what their experience means to them personally in their health, personally. And once you're out of session, educate yourself. Um, and then incorporate addressing historical trauma into your practice with your client. And this includes medical trauma, especially for BIPOC folks. The westernized, the European oriented medical system has traumatized many BIPOC folks historically, leading to mistrust. Um, So talk to clients about how their culture shows up in a clinical setting. Offer feedback forms that ask clients to talk about how they thought the session went, if they felt listened to, validated, and understood. Asking, were there moments in the appointment that something was said that made you feel unsafe? Or the opposite, were you really heard and validated? Do you offer a sliding fee scale or pro bono work? Provide access to communities who are underserved due to their geographic and class, geography in class, or geographic location in class. Um, Invite more system-centered language that does not, as Dr. Megan O'Reilly said, house vulnerability of or issues in the bodies of Black and Brown people. She discussed use of language like vulnerable and at-risk communicates that Black and Brown people are inherently vulnerable and at risk. When those things are really things that the systems in place have created, the structures have created. So instead of at risk, you can use they've been more exposed. Instead of vulnerable, you can use we've been systemically prohibited from healthy or helpful outlets or strategies. Instead of disproportionately affected, you could say systemically impacted. Or underrepresented, you can use systemically excluded. I'd like to uplift this video with the caveat that um, we have to be mindful of who runs the AI and technology field, who is it largely dominated by, and noticing how that plays a part in using AI and technology in the healthcare industry. Again, I really encourage folks to look up this video and take a look. I can link it into the chat box later on. And so on in our healthcare admin and boards, it's not always helpful to create a board for diversity. This piles a lot of work largely on BIPOC folks to save and educate non-BIPOC clinicians, as well as forgive non-BIPOC clinicians for any harm that they've done. But what can be done is requiring multicultural certifications, requiring multicultural trainings frequently, having like a constant assessment of multicultural competency and embodiment. How do you care for the clinicians or workers in the clinic, especially the BIPOC practitioners? Are they being heard? Are they being empowered? Do they feel safe to share their own views on how the healthcare institution is being run? And in the larger healthcare community, what we can do is create consult groups specifically for working with clients or patients of color, where you can share resources, seek guidance. You could create consult groups, caucuses, organizations, and boards specifically for BIPOC clinicians and the vicarious and real trauma that they face on the day-to-day. And this includes trauma within the session, being discriminated against, as we see, you know, on a day-to-day basis. Create diversity study groups to continuously read and learn about diversity, social justice, practices for clinicians, and democratization of the workplace. All healthcare clinicians need to connect with the communities that they serve in a non-hierarchical way. So above all, you will make mistakes. Notice your bodies and your minds, what thoughts you have when you make those mistakes. Notice the physical response that you have when you make mistakes. And take a moment, I invite some breath. Take a moment and ground and hold. This expands your ability to hold yourself accountable for mistakes that you make. Challenge this idea of right and wrong. That is largely a white supremacist, a European-based construct in which there is black and white. You know, there's an enemy and a hero. When in reality, aren't we all just humans? Don't we all make mistakes? So educate yourself, repair the relationship, continue an educational process outside of the relationship, learning about the communities that you serve, connecting with BIPOC clinicians. This builds trust the ability to have difficult conversations, unlearn, relearn, and grow. And so this quote by Paulo says, leaders who do not act dialogically but insist on imposing their decisions, do not organize the people, they manipulate them. They do not liberate, nor are they liberated, they oppress. So asking yourself, how much of an expert are you really on the clients that you have, the patients that you have? Um, what can you know more about? And so we're moving beyond the clinic into how to truly embody anti-racism outside of our patient rooms. This one says, if the structure does not permit dialogue, the structure must be changed. So on a systemic level, practitioners must embody organizers and activists. We're not trained to stop structural violence, but what we can do is build coalitions to meet our clients' and patients' needs outside of the clinic. Here are two pictures talking about structural racism, structural violence. So for example, it highlights on the top left-hand corner, it says structural violence, racism, social class, heteronormativity. And that goes into the neighborhood context. It goes into the individual social position. Um, it just highlights how structures created on a higher level trickle down into um, our individual bodies and our individual processes. So the first part of embodiment is coalition building. This I was inspired when writing this about by the Community Resilience Initiative director Ursula Fallweiler. I served on a panel with her recently, and she highlighted the importance of organizing or joining organizations for things like universal healthcare, deprivatization, and decommodification of the medical and pharma industry. So currently there are some organizations doing the work. For example, Whole Washington is working to get universal healthcare on the Washington state voting ballot, or the larger push for Medicare for all. A quote here from Jill A. Fisher states that a medical system that revolves around pharmaceuticals contributes to a culture of medical neoliberalism. It ties together the commodification of healthcare with the fragmentation of the body, where illness is treated in terms of discrete systems for which there are tailored products. Ask, what has made us portion off the human body in the healthcare system instead of looking at the health of the body as a collective at the within the context of their communities, but also within the body itself? Why do we assign individual doctors to each part of the body instead of having a more collaborative care team? Just curious. Ask yourself, who is health insurance serving? Um, in this coalition building, this can also expand into focusing on organizing for expanded access to quality, affordable, and publicly funded housing and land reform. Geographic location largely informs access to resources, including healthful foods, schools, public natural spaces like parks, organizing, which of course impacts health, organizing for expanded healthcare education in public schools, talking about your health normal from day one, organizing for expansion of infrastructure that meets clients' needs and fights barriers to care, like transportation and healthcare. Childcare. All of these things impact the way BIPOC communities access healthcare. And so organizing and coalition building, joining these organizations that are fighting for these different things together is meeting the needs, is fighting to meet the needs of our clients and patients outside of the clinic. Looking up and learning about community participatory research. Participate and conduct qualitative research, examining biopsychosocial determinants of health is so important. It also helps us connect with members of the community to better understand their own needs, empowering them. And then we have healthcare education. I'd like to invite everyone to ask themselves and others who has access to quality, well-funded healthcare education in the United States. Typically, it's upper economic folks. Typically, it's white folks who have access to generational wealth, legacy, and colleagues, an understanding of navigating post-secondary education, economic privilege, which means living without distressing concern for socioeconomic related mental health and stress, student loans, ability to go to school without working, houselessness, worry about justifying time, cost of education, and their education's financial return. So again, focusing on, can I profit off of my education? Is it worth the time and the loans that I'm putting in now for me in the future to be able to support myself and potentially, usually, supporting my own family, my parents, my grandparents, my brothers and sisters. Access to tutoring, prestigious recommendations in competitive post-secondary institutions. Ask yourself, does a first-generation college student easily understand who to go to for tutoring, what classes to focus on in their coursework, and how to study properly for exams? We are learning from psychology that folks with higher socioeconomic access are shown to be less empathetic. And these are the same people who will have higher access to healthcare education. What does this mean for the healthcare field and for the people that utilize it? When it comes to licensure, we understand that licensure is run by the state and multi-million-dollar lobbying groups with mixed and controversial pasts. Leadership in the past has exhibited racism, and there is significant evidence of involvement with scandals. AMA, APA, and ACA, while they implement very useful standards, and healthcare isn't a field for everyone. So some selectivity, I'm sure, is very helpful. But more people, especially BIPOC community, should have access to top line quality healthcare education, especially economically. It's important to highlight that these are not labor unions. So they're not necessarily standing up for the clinician as a worker, um, but they maintain the selectivity of those who have access to healthcare education. For example, in the past, they have lobbied the government to say that we have too many doctors or we have too many nurses, when in reality, is that ever really true? So continue to ask yourself and others who gives access to licensure, who are these organizations typically excluding, um, who typically leads these groups? Should licensure be tied to finances, multi-billion dollar lobbying groups the way it is? And who is the system of licensure serving determined by these groups? Is our current licensure system truly effective, equitable, social justice oriented, and liberatory? Are they inviting people that have BIPOC patients and clients' needs in their forefront, in the front of their minds? And then thinking about labor, is there really a healthcare labor shortage or is it underemployment? Um, in October of 2021, we saw that the average clinician vacancy rate at behavioral health centers across those centers, across centers was 26%, and the rate 3 months later was 30 to 60%. And it's just highlighting that the workforce crisis is absolutely um, the most pressing concern. Again, how is this um, affecting the way that clinicians show up in the clinic? How is it that their needs getting met is impacting the way that they show up? Um, we see that, for example, community-based healthcare salaries are 20,000 to 35,000 less than those who take private insurance, who see more patients with private insurance. Um, this is asking clinicians, including BIPOC clinicians, including Black and Brown clinicians, to become martyrs for public health care. Oftentimes we see that BIPOC clinicians want to serve members of their own communities. And so where are the members of their communities? They typically are not, they oftentimes are not those that have access to really robust commercial insurance. And so you do find a lot of BIPOC folks in underserved communities in publicly funded behavioral health. So it's a cycle. It's a cycle, really. So asking yourself, is your workplace democratized? Is your workplace unionized? And are you active in your own union? When healthcare workers feel that they have more say in their work, have less workplace stress, and get their needs met, they can show up best for BIPOC clients. We see that increased violence towards Asian healthcare practitioners in the US post-COVID onset, for example, has highly impacted the diversity in healthcare work, and thereby the access that BIPOC folks have to, for example, Asian healthcare practitioners, which was, as we saw earlier, something that was a barrier to healthcare. So when more medical staff is hired, workloads and caseloads improve. And this is especially important for how workplaces and institutions care for BIPOC clinicians. BIPOC healthcare workers should not have to face systemically racist institutions and workplaces alone. And because BIPOC clinicians have historically been stripped of their democratic work rights and ability to bargain for higher wages, better workplace environments, and ability to move between jobs, i.e. Black codes, vagrancy laws, deluxe Jim Crow in the 1870s, labor organizing and democratization of the workplace is informed reparations for BIPOC clinicians. So what's important here is to continue to have a dialogue with those around you. Work with others to create anti-racist solutions for your environment. Ask questions, understand collaboration is necessary, and collective action will help our BIPOC clients and patients. So in conclusion, we see that race is under a global capitalist apparatus is inextricably and historically linked with socioeconomic class. We see that socioeconomics changes the way racial groups have access to resources and systems of oppression impact their lives. When medicine, healthcare, and wellness is commodified for profit structurally, this changes what racial and socioeconomic groups have access to medical and healthcare resources, as well as healthcare education. In our individual practices, there are ways for us to support and meet the needs of specific marginalized groups. But at the same time, healthcare providers can build coalitions to dismantle the commodification in general of healthcare and promote equity, agency, and wellness for our patients and clients. Thank you so much for joining me. And I'll again post those videos in the chat. I'm gonna stop the sharing here. And I also wanted to open up for any questions or comments as well.
Hey, Rachel, I had a question for you. And so, to me, it really sounds as if we as a profession would benefit from doing more organizing and more finding more ways to address these systemic issues as a whole. And I'm wondering for you, as you've navigated your career in the healthcare industry and in the community mental health industry, what do you think are some barriers that are stopping social workers from actually organizing and doing what we're trained to do?
Yes, I think a large part um, is, you know, where the labor organizing space is. Oftentimes it takes space outside of our work. Also, there's kind of this expectation that I think as a field in mental health and social work as a whole, I think there's a field where I think we're broken up. I think we are siloed into different uh, fields, different organizations, different departments. Um, when in a large part, we're all, impacted by very similar things, especially, uh, BIPOC clinicians. Um, so in my own, organizing and getting in touch with the communities that I served, um, just asking what's needed, and having an open dialogue with your coworkers, or having a kind of an after hours chat with your coworkers about things you might be seeing, um, is definitely something that can bridge that gap.
Thank you. We have someone in the chat box saying, "Thank you so much for the very informative and supportive information. It's going to lead to change."
I have a question about the slide about different terms to use other than like disproportionately impacted. Um, I- just I wanted to be able to incorporate that changed language. Is there a place where we can get that to reference and change how we talk about it?
Yes, I would love to direct everyone to pull up Dr. Megan O'Reilly's work. One of the things in a thing that I saw, um, a talk she was giving, um, she talked about creating a compilation of systems. I'm gonna put her name in the chat box. I invite everyone to just Google, search around YouTube. She talked about putting together a database for system-centered language. And I really invite everyone to learn more about it. Um, it's really impactful. Let's see. I went ahead and put some links in the chat there. Yeah, any other questions?
I got one more message to the chat box, and they're wanting to know what other talks you have coming up, what other ways that they can stay and follow your work.
As it stands right now, I don't have any talks coming up. But feel free to, I don't know if I put my information in the chat, but I can put my email in the chat and you can feel free to reach out if you would like to have a conversation. I'm always open to it. I went ahead and put my email there in the chat.
Thank you.
Mhm. And I also, I don't know, Salome, did I give you access to the slides that I created? I could put those in the chat as well, if it's helpful for anybody.
You didn't give me access, but if
Okay.
you could, that'd be appreciated. We send an email at the end where we provide the slides, the recording link, and just a gentle reminder to everyone to complete the forms. We have another person in the chat box saying, thank you so much for this important work, and thank you in advance for the slides. And then I do want to gently remind people that we do have some more events coming up. And let me paste them into the chat box in case anyone's interested. And I did get a message from someone asking for more anti-racism and decolonization events. So we'll be sure to put that on our list of things to bring you. And if you have the time, Rachel, it'd be wonderful to have you come back and continue to help us explore and expand the skills that we've been able to learn today or to refine today. Well,
I'd be happy to.
We have about 6 more minutes, and so I guess if there's any more questions, we'll stay on to support everyone with being able to get their full hour. And if you need to head out now due to trying to run back to work, you're welcome to do so. Thank you. Oh, I got another message. I spoke too soon. I got another message asking for more resources.
Of course. I'd be happy to share some things in chat. Give me 1 second here. I've shared a spreadsheet. It's talking about accessibility, disability justice, decarcerating care, abolition, ableism. Yeah, I invite everyone to take a look. There are like loads of things that they can that you can watch, you can listen to. Um,
This is amazing. Oh my goodness, this list is so detailed. It's so robust. Oh, sorry, I got caught up in looking at the different event titles and the video links. In the chat box, we said thank you so much for your presentation and resources.
of
Rachel,
course, of course.
could you give us a little bit more information on who put this together and how it came about, if you know?
Um, this I'm not sure. I can't remember how I came upon it, but I did not put it together. Just I'm just gonna say that. But yeah, this is a um pretty extensive list. When I find who, when I remember who put it together, I'd be happy to share that.
Thank you. And I see here listed abolition, prisons, and policing. I know that is something for sure that we as social workers have been really talking about and trying to explore and how we can further support abolition work. So I'm curious, Rachel, for you, where do you think as we start incorporating more anti-racism practices and start shifting the dialogue and the systems that we're a part of, I'm curious for you, where do you think our next steps should be?
Um, for me, I typically, when it comes to that question, I typically direct it to everyone else, just because I think that it should always be like an ongoing conversation. Um, I always think that it should be a dialogue that is continuously interrogated. Um, and I don't I try to, learn and unlearn that just one person's ideas are the best. And I'm not saying that's what you're saying, Salome. I'm just kind of illustrating where I typically stand on, on that idea, on that question, I mean. So I invite, all of us to understand that, or allow themselves to understand that, that we all, really have the answers within us, and within each other and within our communities. Um, and so I invite everyone to, from the space, move forward with a dialogue, uh, wherever they work, wherever they live. Um, just talk to people.
Thank you. No, I really appreciate that. And I completely agree with you. Continuing to further the conversation, finding ways to explore what's best for our communities and how do we really incorporate the voices and the needs of the people that we're serving, um, and that are also to a great extent supporting us in the work that we're doing. So thank you. Well, it's 1 o'clock. If anyone has any further questions, feel free to reach out to Rachel. Or if there's any questions you have about your CEUs or upcoming events, feel free to reach out to us at the Coalition. Thank you so much and have a great rest of your days.